So scoliosis in general is a curvature of the spine. And the most common form of that is what's called idiopathic scoliosis, meaning we don't know what causes it. So there are certain times where there could be congenital, where kids are born with it, or neuromuscular, where it's because of an underlying neurologic disease like cerebral palsy or spina bifida, for example. Those are different types of scoliosis. Idiopathic scoliosis, again, is scoliosis. We don't really know what causes it. We have some theories about the genetics and things like that, but right now we don't know what that is. Of scoliosis, 85% of that is adolescent idiopathic scoliosis, meaning that it typically occurs over the age of 11 or 12, typically involves girls, and again, that's the vast majority of what we see in terms of scoliosis. So one of the things about adolescent idiopathic scoliosis is it's typically painless, and it also occurs around the time of the growth spurt. So typically for girls, that's around 11 or 12, maybe 13, and boys a little later. So because it doesn't hurt, it's important to screen for it. And so our pediatricians here in the community are very good at looking at this during the well-child exam. A lot of our kids come to us from school screenings for sports physicals and things like that. And so I always tell patients it's about a third, a third, and a third. A third of the time they come to us because they notice something different in their daughter or son's appearance, or maybe the son or daughter does. A third of the time it's picked up on a routine screen, maybe a school physical or a gym screening. A third of the time it's just what we call an incidental finding. They may get a chest x-ray because they have a cold, or an abdominal film because they're sick to their stomach, and we see scoliosis. So the key is it typically doesn't hurt. The other thing is it occurs around a time when kids are more modest. So at 13 or 14, you may not see your child undressed as much as you did when they are 3 or 4 years old. So there's a lot of factors that go into that, but the hallmark is it's painless. The good news is the vast majority of patients with scoliosis tend to have mild cases that don't cause any long-term problems. It's important though to get checked just so we have a baseline, so that if you do start to progress or change, that we can intervene early. If you took it step by step, the first thing that we would do other than observation is a brace. And a brace is usually used for kids with curves in the moderate range, somewhere around 25 to 40 degrees when kids are still growing. The issues with bracing are that braces don't make curves smaller, they just keep them from getting bigger. So the whole goal of a brace is to try to keep the child out of the operating room. It takes a compliant child, compliant family. Bracing may be 16 to 18 hours a day. While that sounds pretty difficult, actually most families do very well with it. So the mainstay for curves that start to get a little bigger is a brace. I would say in 2020, I think the most commonly performed surgical procedure for scoliosis is what's called the posterior spinal fusion. That's where we'd make an incision in their back, use metal rods to straighten out the spine, and then allow it to heal. There are some newer technologies that have come on the market. They've been released by the FDA. We're fortunate here at Campbell Clinic that we're one of the first 20 centers in the U.S. to have these devices released to us. With any new technology, such as the ApiFix device or the vertebral body tether, or VBT, we're very cautious about who we use them on and when, because with any new technology, I think there's a learning curve, and we need to be very careful about the use of those new technologies. So the good news about scoliosis is a vast majority of kids do really well. 3 to 4% of kids here in Memphis or anywhere have scoliosis. The kids that we tend to intervene on surgically are more in the 1 in 1,000 range. So small curves are very common. Big curves that we need to treat tend to be fairly rare. The good news is it tends to be driven by growth. So if you finish growing with a small curve, your curve is going to stay small, and you can do very well long term. So a lot of our patients we see in the adolescent years go on to have full, healthy, active lives as adults. Some of our patients actually go on and compete in athletics even at the highest levels. The curves that are a little bigger, the ones in the 40 to 50 degree range, may have some problems later in life, and those are the people we tend to watch a little longer. And then patients with larger curves, those we consider greater than 50 degrees, in the long term tend to do fairly poorly in terms of long-term pain and pulmonary issues, and those are the people that we tend to recommend for surgery. I think the good thing about scoliosis in terms of surgical treatment is nothing's an emergency. There are certain things we do in orthopedics, whether it may be an infection or a broken bone, where it's doing emergency surgery, where the patient doesn't know us, we don't know the patient, and that's a really challenging thing for all of us. So I'd say the optimal age is typically in the teenage years. The longer we can delay surgery and let the child finish their growth, the better. Practically, you can do surgery into the early 20s. The hard part is these are young adults in the prime of their life. They're finishing school, they're starting families. So it's very hard to get young adults back in their 20s for surgery. One of the other good things about, I think, surgical treatment of adolescent scoliosis is that most patients do really well long term. It's a little different than some of the adult back problems that are more degenerative, and so in adult back surgery sometimes the reoperation rate's a little higher because of the underlying problem, whether it's arthritis or disc disease. So our reoperation rate for adolescent idiopathic scoliosis is somewhere around 5%, so very rare. Most people go on and lead very active adult lives. We have people playing sports at all levels after surgery. And so the outcome's very good long-term, even for patients that we treat with surgery. I think one of the most important things for parents is that because it is painless, it's important to be watching your child. And you can do some very simple things at home. So you can get them in a pair of shorts or a bathing suit, look at their shoulders, look at their waist, look for symmetry. In the clinic here, we have them lean forward or bend forward, and sometimes you'll see a rib hump or some asymmetry between the sides of their thorax, the left and right side of the ribs. So you can do simple things at home to look for symmetry. If you have any questions, you can either come see us or see your pediatrician. We have very good pediatricians here in town that are familiar with making the diagnosis of scoliosis. I think we're very fortunate here at Campbell Clinic to have the resources not only of Campbell Clinic, but our partnership with Le Bonheur and St. Jude. We perform 80 to 100 of these spinal surgeries a year for adolescent idiopathic scoliosis, and everything we do is really teams. Your outcomes are better the more that you do of it. So we not only have cutting-edge technology, both here at Campbell Clinic and Le Bonheur, but very experienced teams that help us get the best possible outcomes.